So welcome, Jennifer and Sandra. I will hand it over to you and for a fabulous presentation today. Thank you.
Thanks so much, Vicki. We'll get started and I'll screen share my slides and then we'll get underway. Thank you everyone for joining today. As Vicki said, please throughout the presentation, put questions into the Q&A or the chat box, and we'll have some time at the end for them. Everybody who knows me knows I get very chatty, so if I stop for questions, we'll never get through. So we'll look forward to having that discussion at the end. So just some brief introductions for ourselves. Our talk today is Transitioning from Pediatric to Adult Healthcare Services, Understanding the Personal and Population Level Experiences of Youth with Intellectual Disabilities. I'm Dr. Jennifer Baumbusch. I'm a professor at the UBC School of Nursing and a CIHR chair in Sex and Gender Science. Sandra, do you want to introduce yourself?
Yes, so my name's Sandra Marquis. I'm a PhD. I'm doing my postdoctoral research with Jennifer. She's my supervisor, and this is the work that we've been doing together for the last 3 years now. So this is the reporting of 3 years of work, and I'm very pleased to be here and doing this.
Thanks, Sandra. So Sandra and I are going to go back and forth a bit during the presentation, and I'm going to be doing the slide sharing. So we'll be going back and forth a bit on that too. We'll start with some acknowledgements. The funding for Sandra's postdoc came from the Michael Smith Health Research BC Trainee Award, which has been really key in supporting her work over the last 3 years. Co-investigators on Sandra's project include Yona Lunsky, Nadine Esme Marquis, and Kimberlyn McGrail, names that are probably familiar to lots of you. The graphics that we use in this presentation were created by Diana Salcido, who's a very talented graphic artist. And there's some visual storytelling from my daughter, Eleanor. And I just want to acknowledge and thank her for her permission to share parts of her story with you today. So in terms of what we're going to talk about over the next hour, we'll be introducing the topic. Sandra will share methodological and study results from her research and some key takeaways. And then I'll be talking a little bit more about moving from cliffs to bridges, which is a metaphor that's often used for transitions in this situation, and recommendations for supporting families as they move through this life course transition. And then, of course, we'll have time for the Q&A. So transitions in care, what are we talking about? One of the things that we need to consider is that the life expectancy of people with intellectual and developmental disabilities is extending. And so we have more and more youth who are transitioning from pediatric to adult health services. And adult health services haven't necessarily been built and prepared to care for this population. So what we currently know is that in general, people with intellectual and developmental disabilities experience poorer health and health care compared to people without intellectual disabilities. And that life course transitions, including the one from pediatric to adult health services, have been identified as among the most difficult times for health care of this population. And we know from previous research across many health issues that youth with intellectual and developmental disabilities have worse experiences and outcomes than those without. And these include worse mental and physical health, and at the time of transition, an increase in psychiatric hospitalizations, increase in medication use, and increased use of emergency department services. So when I work with Sandra, my background is actually mostly in qualitative research. And so it's always interesting for me to enter the world of population-based research. And I wanted to share these pictures of my daughter, Eleanor, because it's so important to remember when we're talking about population level research that it's about individuals and that there are people behind these numbers. So as you can see, Eleanor is a very happy person. She has lived a very busy life to the extent that she can. She graduated from high school a couple of years ago. And so Sandra's research really touched me deeply because we are actually going through this process as she was doing her research. And so many of the topics that she'll talk about are things that our family have gone through and different areas of the healthcare system we've come in contact with. But I'd like to show these pictures to show that these youth are people who are out in community, living their lives. They don't want their healthcare issues to be the focus of their time. They have other things that keep them busy and that they want to be doing. But at the same time, they do spend an inordinate amount of time interacting with the healthcare system. So these are pictures from Eleanor's healthcare experiences over time. She's had many hospitalizations because in addition to being intellectually disabled, she is medically complex. And she's an ultra rare genetic difference of which she is still the only recorded person in the world. And she spent a lot of her childhood based in the hospital, having operations, seeing specialists as an outpatient. And very recently, you can see her there in the dental chair, having specialized dental care. So this is also a big part of her life and a big part of her journey. So I also wanted to show these pictures before we get into Sandra's story, so you can really see that, again, there's a person behind each of these numbers, and it's really important to be thinking about that as we're planning and acting as clinicians and policymakers. So with that, I'll hand it over to Sandra, who's going to share more about her research.
Thank you, Jennifer. So it's always a nice way to start with an individual because now we're going to leap into population level administrative data. And this really deals with large numbers at the population level in British Columbia. So this study or series of studies use population level administrative health data to assess the health of youth who have intellectual developmental disabilities as they transition to adult health services. And as I've said, we use population administrative health data. That's accessed through Population Data BC. And this is the data that is collected for everybody that accesses healthcare in the province. So when you go in to see your doctor, they will complete some paperwork that includes a code for what you saw them for, and then that is attached to their billing that they submit to the Ministry of Health. And the Ministry of Health collects that data, anonymizes it, so strips it of any identifying information, and provides it to researchers on application. The researchers have to apply and go through a very rigorous process of being eligible to apply for the data and to receive it, and then it can be used for population level research. So what we have, or what I have, is ICD-9 and ICD-10 codes from physician diagnoses. And these are the codes that a physician would attach to the paperwork that signifies what the patient was there, what the reason for the visit was. And so if I went in and I was diagnosed with some kind of flu, then there would be an ICD-9 diagnosis code for the flu. If I was in the hospital and I was diagnosed with something more serious, then there would be an ICD-10 code for the hospital billing data. And we looked at the whole population of youth in BC over a 10-year period. So from 2010 to 2019, and we looked at youth that were aged 15 to 24. First of all, I looked at that whole group as a large group, and then I subdivided it down. So I looked at each of the people that we had data available for who were 15 in 2010, 16 in 2011, 17 in 2012, and so on up to age 24 in 2019, so that we could follow them progressively. And I used a logistic regression and difference in differences analyses to look at that data. Next slide, Jennifer. Thank you. So this is the just the descriptive statistics for youth with intellectual disabilities and youth without intellectual disabilities in BC from 2010 to 2019. So we were able to find 20,591 youth with intellectual disabilities and compare that to youth without intellectual disabilities, and there was almost 1.3 million of them. So in the population of youth with intellectual disabilities, about 68 or 69% of them were male, and 31% were female. And this is slightly different than the non-intellectual disability population, but that has a more even distribution of males and females. One of the things I looked at was income levels and poverty levels. So the MSP subsidy was available for anyone who could not afford to get medical services coverage until fairly recently. So there is also a flag in the data that says whether the person received a subsidy or not, and we use that as a marker of low income. And so you can see that there's a much higher level of low income in the population with intellectual disabilities compared to the other population. And again, if you look at the income quintile, you'll see that there's more people with intellectual disabilities at the lowest end of the income quintile compared to the non-intellectual disability population. Next slide, Jennifer. And then we looked at the type of intellectual disability diagnoses. So of our population of about 20,000 people, 11,000 had a diagnosis of autism, 967 had a diagnosis of Down syndrome, almost 2,000 had a diagnosis of fetal alcohol syndrome, and then I had to create another category that I just called other, that anybody that didn't fit into autism, Down syndrome, or fetal alcohol syndrome was put into, just because the numbers are so small for all of those other populations. And we're constrained somewhat by the data about what small numbers we can look at. So I bunched those into the other category. And then I also looked at people who might have more than one type of diagnosis. So for instance, if you were diagnosed with both Down syndrome and autism, for instance, I compared a group that had a single diagnosis compared to groups that had one or more diagnoses. Next slide, Jennifer. So the very first thing we looked at was dental visits. It's a little bit hard to track in BC because the information is not available for regular office dental visits. The only dental visits that are tracked in BC are the ones that are deemed medically necessary. So those are ones that primarily occur in the hospital. But as we know, people with intellectual developmental disabilities receive dental care in hospitals much more frequently than people without intellectual disabilities. We knew that sort of from other data, but we didn't know that exactly in BC. So this is what we found in BC, and that was that the odds of people with intellectual disabilities receiving dental care in a hospital were 7 times that of people without intellectual disabilities. And so this may mean that people are going in for things that can't be done in a regular dental chair, but it most often means that people with intellectual developmental disabilities are going into the hospital for what would be considered regular dental care. So they're going in for dental caries, they're going in for impacted teeth, they're going in for anomalies of tooth position, things that people without intellectual disabilities might just be treated for in a dental chair in a dental office. Okay, next slide, Jennifer. And we looked at the difference between the younger group, so the youth aged 15 to 19, and the youth aged 20 to 24. And there was something really interesting here, and that was that dental visits, medically necessary dental visits, tend to decrease with age. And we can't tell exactly why that is happening. That's one of the things about population level data. It gives you numbers, but you don't necessarily know why those numbers are occurring. But one of the things we might guess is that pediatric dental care is funded at a higher level than adult dental care for people with intellectual disabilities. So one of the reasons for a decrease in dental visits as people age and enter the adult healthcare system is that they're just not funded as well for dental visits once they've turned 19. One of the things I looked at was, well, maybe they just have less dental issues as they age, but the evidence in the rest of the literature is that people with intellectual disabilities often have increasing dental issues as they age. So it is a concern that if they might have increasing dental issues, but they are actually getting less dental care, then dental care is really could become a very large issue for people as they age. Next slide, Jennifer, please. The next thing we looked at was mental health. So we looked at both depression and anxiety, and we looked at diagnoses for psychotic illness. And in both of those cases, the odds of somebody with an intellectual disability having a diagnosis of depression or anxiety is 3.6 times what it is for somebody who does not have an intellectual disability. And the odds of someone with an intellectual disability having a diagnosis of a psychotic illness is about 7 times, again, what a youth without intellectual disabilities, the risk of a youth without intellectual disabilities having. So again, much higher levels of mental health diagnoses occurring in our intellectual disability population, both depression and anxiety and psychotic illness. Next slide, Jennifer. And again, we looked at that. How did that change over time? So with depression, it was interesting. Depression and anxiety, the diagnoses for depression and anxiety actually, the odds ratios for those decreased over time. So the highest rates of depression and anxiety for people with intellectual disabilities seem to happen between 15 and 19. Whereas for youth without intellectual disabilities, it increased with time. And for youth with intellectual disabilities, it decreased with time. And again, the data doesn't tell us why that necessarily is. It could be that 15 to 19-year-old time period is a very stressful period for people with intellectual disabilities, as they're anticipating that they're going to transition out of high school. A lot of services change at that point in time. Healthcare changes at that point in time. Or the other option is they're just not, once they leave pediatric care, they're just not receiving the same level of care as they would have prior to age 19, because they're not eligible for youth services anymore, or for child services. Next slide, Jennifer. Interestingly enough, the opposite happens with psychotic illness. So the mean number of diagnoses in youth of psychotic illness in youth with intellectual disabilities is 10.89 in their 15 to 19-year-old age, and then increases to 14.62 as they age. So while anxiety and depression seem to be going down somewhat, the diagnoses for psychotic illnesses are going up. And again, I can't tell you why necessarily that has happened. We can hypothesize that they're being treated differently once they leave pediatric care, or there is an actual steep increase in psychotic illness. Yeah, so we don't know. There is also an increase, if you look at the other column there, the youth without intellectual disabilities also increase over that age span. So it might just be I wouldn't want to say regular, but the increase that's happening in the total population as well. But it's a much greater increase in youth with intellectual disabilities. Jennifer. All right, so the next thing we looked at was gynecological issues. So we compared female youth with intellectual disabilities to female youth without intellectual disabilities. And there was really not a significant difference between the two. So the odds of having going to the doctor and having a diagnosis of or a visit for some gynecological issue was this pretty well the same for female youth with intellectual disabilities compared to female youth without intellectual disabilities. Next slide, Jennifer. But what was really interesting, I think, was that the mean number of visits for youth aged 15 to 19 was higher than the mean number for youth without intellectual disabilities at a younger age. And it decreased for youth with intellectual disabilities, but it increased for youth without an intellectual disability. And one of the things that I don't actually have on here, but we also looked at was just PAP tests. So we looked at PAP tests, and PAP tests, youth without or youth with an intellectual disability receive a lot fewer PAP tests than youth with intellectual disabilities. But when you look at pregnancy data, for instance, the youth with intellectual disabilities are definitely having sex and getting pregnant. So it is a concern that they're not receiving the same kind of gynecological care as they age as youth without intellectual disabilities. And they're not receiving PAP tests at the same level. So why are they getting gynecological care earlier than youth without an intellectual disabilities, and then why is it dropping off as they enter adult services? I think is a question that we need to explore further, because it indicates somewhat that they are getting gynecological care from their care providers when they're still within the pediatric care, and then they're not getting gynecological care once they graduate out of the pediatric care to the same extent. So again, these are big numbers. We're dealing with large numbers of people, and they tell a story, but the details of the story, I think, are something that we need to explore further. Jennifer. So emergency departments, we also looked at emergency departments, and this was also really interesting. I'm kind of a data person, so I find these things interesting. Odds of a visit to an emergency department for youth with intellectual disabilities was 1.7 times what it would be for youth without intellectual disabilities. But if we added into there the fact that youth with intellectual disabilities had a higher rate of diagnoses for psychotic illness, then that really reduced the odds considerably. And what that's telling us is that quite a few of the visits to emergency departments by youth with intellectual disabilities are due to either psychotic illness or anxiety, depression. So again, what that's telling us in the very big picture is that these youth have fairly high levels of mental health issues, and they're not necessarily being treated in doctor's offices. And so they're ending up in emergency departments because of their mental health issues. So again, it's big picture, but it's pointing us in the direction of these youth have real issues in terms of their mental health and the fact that their mental health is not being addressed adequately, especially once they leave pediatric care. Jennifer? And as you can see, we looked at just the change between youth age 15 to 19 and youth age 20 to 24. And in both cases, youth with intellectual disabilities and youth without intellectual disabilities, the use of the emergency department goes up quite steeply after age 19. And so it follows the same pattern in both groups that we have. but the mean number of visits for youth with intellectual disabilities still remains significantly higher than the mean number for youth without intellectual disabilities. Jennifer. All right, so we started digging into mental health issues a bit more, and one of the things that we looked at was just the use of antipsychotics by these youth. The use of antipsychotics dispensed to the youth with intellectual disabilities is almost 11 times higher than what it is with youth without intellectual disabilities. And even if you account for the fact that some of these youth have a diagnosis of a psychotic illness, the odds still remain much higher for youth without or youth with intellectual disabilities compared to youth without intellectual disabilities. So youth with intellectual disabilities have 7 times the odds of being dispensed an antipsychotic, even if they don't have a psychotic illness. So that brings up the question of, if they don't have a psychotic illness, and what are these antipsychotics being dispensed for? And again, I can't answer that question, but it points us in the direction of we need more information. We need more information about why antipsychotics are being used so much in this population. We need information about are they being reviewed? Are these youth on these antipsychotics for a long term? And if they're not being used for a psychotic illness, what are they being used for, and are they being used appropriately? Next slide, Jennifer. And one of the ways we looked at that, again, because this is big data, I can't just ask people, I'm only looking at the numbers, is we looked at dispensed metformin. So metformin is the first line of treatment for type 2 diabetes. And one of the side effects of use of many of the antipsychotics is weight gain and increased risk for type 2 diabetes. So one of the reasons for looking at metformin was are these youth, if they're being dispensed antipsychotics, then having a higher risk of developing type 2 diabetes? And it looks like, yes, indeed they are, because they have 4 times the odds of being dispensed metformin compared to youth who do not have intellectual disabilities. And again, this paints a very broad picture, and we need more detailed information. We need to know how long youth are on antipsychotics, what they're on antipsychotics for, and what the long-term effects of that antipsychotic use is in this population. Next slide, Jennifer. So what did we find overall? What changed? What stayed the same as youth left pediatric services and went to adult services? So visits for medically necessary dental issues went down. And as I proposed, this might be due to the fact that dental care is not funded as well for adults with intellectual disabilities as it is for children with intellectual disabilities. So people just can't afford to go to the dentist. And visits for depression and anxiety also went down, but visits for psychotic illness increased as people aged. Visits for gynecological issues didn't change, which is a bit of an issue, because in the non-intellectual disability population, visits for gynecological issues increased steeply over this age group. Visits to an emergency department definitely increased as people aged, and antipsychotics dispensed also increased as people aged. Next slide, Jennifer. So what are key takeaways? Continue studying this important aspect of healthcare for people with intellectual disabilities, and we should be looking at their health holistically, so that we're not just looking at everything in isolation, because a lot of these things are related. If you If you're diagnosed with a psychotic illness, you put on an antipsychotic. Are you more likely also to be using the emergency department? We need to provide much better dental care for this population. The literature says very clearly there's not enough dental professionals for people with intellectual disabilities, and there's not good dental coverage of services for people with intellectual disabilities. We need much better mental health care for people with intellectual disabilities. We need more mental health care professionals trained to work with people with intellectual disabilities, and we need much better access to services. We need to ensure that females with intellectual disabilities are receiving appropriate gynecological care, and we need to ensure that adults with intellectual disabilities have a primary care provider that has knowledge and training in care for people with intellectual disabilities. Okay, Jennifer, you're next.
Thanks. So now I'll pick it up and continue along with some of our story about what has happened over this period of time of transitioning. So as I said, the metaphor of cliffs and bridges is often used in reference to this stage of life. And I recently wrote a commentary that is published in Pediatrics and Child Health about our family experiences. I'm going to share some further metaphors about how this experience has gone. And I liken it to relationships, because there's a lot about relationships as well that doesn't necessarily get captured in the population level research. And so these are some of the things that happened to us over the period of time that Eleanor was transitioning. So the first one was a Dear John letter. This was a form letter that we received in the mail in the summertime after Eleanor had graduated from high school. And it was ending a 14-year relationship with her school-based allied healthcare team. There was no discharge summary included with the letter or any contact from the actual clinicians who had worked with her over a prolonged period of time. And there was no transition initiated. There was a phone number for a generic intake line for our local health authority that I am responsible for calling to start any supports that Eleanor needs from allied health or nursing as an adult. And there was no assistance given to do any of this. The next thing that happened was a little story of it's not you, it's me. And so if anyone's ever said this to you, you know it's usually actually is about you and not about them, but it's an easy out for them. And this is with a specialist who had followed Eleanor for at least 15 years. They had been responsible for a lot of her care, a lot of her hospitalizations. And so this wasn't like a place where we had seen this person once a year. This was multiple visits a year. It was a long-term relationship. We really relied on them for a lot of her health care. And at appointments leading up to her sort of getting into the transition years, I constantly asked this person, you know, are you planning to discharge Eleanor? What does that support look like as an adult? So I was initiating a lot of the conversation, and all along they were like, yeah, everything's great. Everything's good. Don't worry about it. And we got to her last visit a couple of years ago, and the person said to her at the end of the appointment, well, this was your last appointment. I'm not going to see you again. There's nothing more I can do for you, and you're doing great, which she's not, and good luck. And we were both utterly stunned. And I said to them, well, are you making a referral to an adult specialist? And they said, no, because nobody does what I do. And I was like, well, clearly her issues aren't resolved. What is the next step? And they're like, well, you know, maybe you could do this or that. But there was no movement on their part to actually help form that transition or think about what the next steps were. And again, no discharge note or anything for me to even take along to the next person. The last one that was a bad breakup was just ghosting, where you just never hear from the person again. And this was with a clinic that had followed Eleanor for at least 15 years again, very long-term relationships. We're responsible for a very important aspect of her care that relates to her quality of life. And when I contacted them, after we hadn't heard from them for a really long time and an issue had arisen, they said, well, she's discharged. She's over 19 or over 18. We're not going to see her anymore. And I said, well, when were you going to let me know? And so they allowed her to come back for 1 or 2 more visits just to resolve the really critical issues that needed to be resolved. But again, there's no discharge summary that I've ever received or that was ever written. And there was no help offered in the transition. And when I asked them and I said, obviously this is going to be a continuing part of her care, what do we do next? The person actually said to me, well, it's really complicated, Jennifer, and really hard to do. And I thought, well, then why is it my job? If you as the clinician who's an insider in the system thinks it's hard to do, what am I supposed to do? And then they handed me the same generic number that I had gotten in my Dear John letter. So clearly there's a real message that as a parent and as a caregiver, this is all on me, and that I wasn't going to get any help from these people who had had years-long relationships with Eleanor. And this doesn't touch really even on how Eleanor felt about these breakups, because it did hurt her deeply to just never see these people again in a lot of instances and not have closure around those relationships. But we did have one good experience, and I really also wanted to focus on that. This is what I consider to be the handover. And so in this situation, and this is also what tells me that it is possible, because we had this experience and we lived it. So I know it's possible for it to happen with others as well. So the early conversations around transition were actually initiated by the specialist. So again, this is a specialist we saw multiple times a year. They started to talk to us about, Eleanor's going to need to start to see someone new because this is pediatrics and she's going to need someone in the adult healthcare system. They then talked to us about who that specialist might be. And it was someone that they knew and felt would be a good fit for Eleanor because she is so complex and because she has a hard time connecting with new people and new providers, and building that trust and rapport is really important in their relationship. So he actually picked out a person for us and then made the referral. And when we didn't hear back from the referral, I contacted the pediatric specialist, or he followed up with me, I can't remember, but I said, we haven't heard from them. And he said, okay, well, I'll contact them again. And then he followed up on his referral. And then he said to me, I will continue seeing Eleanor. I'll continue to be your person until you start seeing that adult specialist. And so I had the confidence and knowledge knowing that if something urgent came up, I could reach out to that person. And then once we saw the adult specialist and settled into that relationship, I let the pediatric specialists know, and we had a very nice departure and handover because I felt that that was complete. And when I think about these handovers, I also liken it to, as a nurse, when I'm working a shift, I would never just walk out, right, on my patients or my residents, because my background's in long-term care. There is a handover, whether it was a taped handover or a verbal handover. It was never like I could just leave and not tap out to the next person. And these experiences and these transitions are the same, in my opinion, that there needs to be a very intentional handover from the pediatric person or system to the adult system. So just some recommendations. I think a lot of times recommendations around transitions are very focused on the work that parents and youth need to do around, initiating all of this. I obviously have a bias that I don't believe that the onus of all of this should be on the family. I believe that as healthcare professionals, we have a professional obligation to do discharge planning and transition planning and complete that. And so the first recommendation is really to ensure that you're using a trauma-informed care approach that is relationship-centered. For someone like Eleanor, who is so deeply embedded in the healthcare system, and I know that's not the same for every youth, but for her it was, the hospital was actually a place she looked forward to going to. It was a place where people recognized her. It was a place where people asked her how she was doing. It was a place where people celebrated her successes, and she got a lot more positive feedback in that environment than she ever did in high school, from her teachers, from her peers, from anybody. So for her to understand that we were no longer going to that place to receive her care was quite traumatic, and just added to and doubled down on all of the traumas she's already experienced as a person with disabilities, who interacts frequently with the healthcare system. So it's really important to keep that relationship at the center. And then providing comprehensive discharge planning and handovers. I think this is, again, just a fundamental part of what we do as healthcare professionals. You don't let go until the next person takes up that hand. One of the huge barriers to this is the lack of an integrated electronic healthcare system. So Eleanor's pediatric chart information doesn't follow her into the adult system. And for someone who's so complex, what I'm really noticing now that we're using more services in the adult healthcare system is that they have no understanding of how complex she is. And so some of the things they're recommending are things that are absolutely contraindicated, but they wouldn't know that because they have no access to her previous chart. And then I think really confronting ableism in education, in workplaces, and systems level policy. So a lot of what Sandra had talked about, I think, relates to this issue. So when you start to access the adult system, for an example being mental health, a lot of people will say, well, we don't treat people with intellectual disabilities. I don't know how to work with them. And so there's not just the mental health system itself that's difficult to access, but this very small wedge of it that is willing to work with people who have a dual diagnosis. And so this means wait lists are incredibly long, and that it's very difficult to access expert care. And we all know what happens when that is the situation, is that prescriptions get written for things that maybe that person wouldn't need as much if they had other aspects of mental health supports in place. So we really need to think about and reflect upon what is happening within our education systems, within our workplaces, and within sort of those policies that are at the systems level that are barriers for this population to access care. So I'm going to conclude just sharing some of the publications. You can see Sandra's been super busy during her postdoc. Lots of these papers are already published. Some are in process. If you'd like to access any of them, I encourage you to email one of us, and we're happy to send them to you if they've been published. I also wanted to highlight some other work that Sandra's done over her postdoc. I'm really proud that we co-authored the first ever chapter on ethics of caring for people with disabilities in what is a very well-known bioethics textbook in nursing, Towards a Moral Horizon. I'm grateful to Dr. Patty Rodney for inviting us to write this chapter, and it's available through open access, so you don't have to pay for that. We also, Sandra published, and just today we got the news that it's out, a paper on health policy narratives contributing to health inequities experienced by people with intellectual and developmental disabilities, new evidence from COVID-19. If you follow this area at all, you know that there were terrible inequities for this population during the pandemic that led to many deaths and other poor outcomes. And the last one I wanted to share was a realist review of programs for siblings of children who have an intellectual or developmental disability, where we really looked at the evidence base for different programming to support siblings who are such an important part of the lives of people with intellectual and developmental disabilities. These are some of the other references that we relied on and drew from in this presentation. And again, I managed to spell my last name wrong, but you can contact us by email if you'd like to have any of the papers we've talked about or continue the conversation after this webinar. So with that, I will stop sharing and see if there are any questions for the Q&A.
There we go. I'm here.
Oh, good. Okay, I will mute myself.
I'm here. I'm here. For some reason, it was not unclicking. We do. Just before we get into Q&A, I just want to say a huge thanks. Wow, that's a lot of information, and in a really good way. I mean that and an eye opener. So I'm just going to go through these questions one by one. Do you want me to read them out, Jennifer and Sandra? Is that the best? I can read them for everybody, and then okay. So our first question is, does the POP BC data include visits to walk-in clinics and urgent care, or just primary care visits for youth with an ongoing relationship with a GP?
Yeah, that's a good question. No, it would include walk-in visits and urgent care. What it doesn't include is any visits to nurse practitioners, or any care that's provided by physicians providing care on reserve. So those two are left out.
Thank you. And this is a question from Judy. Hi, is there any research regarding youth with an IDD transition into health home and community care, healthcare support services, such as home support, especially for high intensity personal care support needs individuals?
So no, at this point, no, we don't have access to that data. It's actually something that Jennifer and I have talked about and is a potential for looking at down the road. But at this point in time, we don't have access to that.
Great, thank you. And there's a comment from Erica that says, just a comment. Thank you for all of this research. There's very little available to support advocacy, and these are all great resources. So I will open it up for anybody else who has questions.
I think Tessa also had a question, Vicky.
Oh,
Question about your thoughts around pediatric system planning to better address transition. There have been so many projects over time to try to do this better, but still the system fails short. Thoughts on what the system can do better to address these shortcomings? I'll take that first because I have many opinions, and then Sandra can chime in. I think the issue of discharge planning and writing a discharge note and sending those to families to carry on with whoever is the next person. We're just sitting here with no discharge information. And so you have years and years and years of care, and it's all reliant on me to be the narrator of that. And that's not okay. Because I may not be a reliable narrator at times. And so if you're going to discharge someone, especially like a medical specialist after over a decade, I need to have a really comprehensive discharge note. If you're a clinic, I need to have a really comprehensive discharge note. It's not sufficient just to say goodbye. And I think that's very basic. And I was absolutely shocked that at that very basic level, it's not being done. And so that's one thing. I think that we have health services for community living in British Columbia, and I'm not going to go too deep into what that is. I know there are people on the call who'll be familiar with it. But again, I was really stunned that Eleanor, as a student who's diagnosed with intellectual disability, is in a life skills program, that program, the HSCL, doesn't reach into the schools. They know who those students are. And so that's a collaboration between health and education that I think is completely missing and should be there. It shouldn't be up to me to call and explain to somebody who's, you know, taking a call on the big open line of my health authority around HSCL and needing a referral there. That should all be done and taken care of. The electronic health record is a huge, huge piece, I think, because Eleanor has a 15-volume chart at Children's Hospital that's now not accessible really to anybody. And so we recently had our first experience, for example, at a large tertiary hospital emergency room around an emergency dental care issue. And it was a real struggle because although we received excellent care, it left me thinking, what would this be like if they could open her chart and know who she is? Because it was a very superficial level of care, understandably, because they don't have any of the history. They don't have time to ask all that history. So being able to access that, I think, would have made the experience even that much better. And so those are just a few things, I think. And then also, I guess my last point would be around education of healthcare professionals. I haven't done a formal audit, but I don't think there's a lot of formal curriculum for just foundational knowledge of working with this population. And so it's constantly parents and caregivers educating people about what it's like. And I had a nurse on Eleanor's last inpatient hospitalization say to me at the end, I learned so much from you just observing how you communicate with Eleanor. And I thought that's great, but you should be learning some of that in school, because some of the nuances of caring for this population are things we should be teaching across the health professions. Knowing that their rates of using healthcare services are so high, you're going to interact with them and you should know what to do. So Sandra, I don't know if you want to add more from your perspective.
Yeah, I would just agree with you about all of that, but also I think too about the training of healthcare professionals. I really do think that there's a lack of training in medical schools around disability and intellectual disability in particular. And I also would say I was at a just yesterday at the Transition Hub meeting, and a lot of these, and it's a national kind of organization that's looking at transitioning, and a lot of these same things keep coming up. And I would also have to say that just lack of resources, like, you know, medical care professionals are also hampered by the fact that they just don't have the resources and funding to provide the care that they might want to provide, but just are not able to. So, you know, longer appointments, you know, assistance with communication during appointments, you know, being able to go back fairly soon after an appointment to follow up on things. Those things are just not available enough, I think, in our medical system to deal with people with intellectual disabilities that need those extra services.
Thank you. And Emma has a question, and says, I'm curious if you came across Foundry centers in your research. Do they play a role for youth transitioning?
Sorry, what centers?
Foundry centers.
Foundry centers. I have heard of them, but I don't know anything about them. Jennifer?
I don't think it got that granular in Sandra's research. I would love to know what the Foundry centers do for this population in transitions, because we're more familiar with the mental health stream for people who have intellectual disabilities. And it would be, I think, very interesting to know how the Foundry supports this population as they transition to adulthood.
Thank you. There's a whole other project. What's Foundry up to in those things? Few more questions. Judy, how does an adult living with disabilities access nursing services when living at home and requiring nurse oversight for medication adjustments as needed 24/7, for example, brittle diabetes, adrenal insufficiency, etc.?
You want to answer that, Jennifer? You know more,
Sure.
more than I do.
I mean, I think that we have, and we went through this as a part of the transition process, was having the inter-eye assessment done. Eleanor did not meet the criteria for that. And I think, Judy, your question also speaks to a broader issue. A lot of my research is with older people, and that when you have people who are medically unstable at home, how do we provide round-the-clock support for them to live in community? This is a huge challenge, I think, for all places. In British Columbia, we do have some, you know, for youth, we have nursing support services. In adult care, a lot of times there's a push for people to move into long-term care homes or group homes. And so I think this is a challenge for the healthcare system. As I started out by saying, people are having their life expectancy extended. And so the pediatric system is maybe more clear in how that population is cared for by regulated nurses. I find the adult system is like, oh, someone under the age of 65 needs round-the-clock regulated nursing care in community. What does that mean? And we're not there yet. I don't think that we have a very good system that supports that, that type of community living for people with disabilities at this point in time.
Thank you. And building off that, Sandra has a question that says, from your perspective, what priority intervention could we develop / implement in the adult acute / critical care setting to move practice forward?
Definitely more education for physicians, I think. And I would include in that dentists. I think there are very few dentists that are comfortable with the adult intellectual people with intellectual disabilities. So yes, I think more education. It's very difficult. You know, medical education covers a huge array of issues. The intellectual disability community is about you know, 2% of the population at the most. So to push that agenda forward, it's difficult to make a case. But in the meantime, we have, you know, 20 to 25,000 people in BC whose healthcare is suffering. So yes, I would say that. I would just say awareness as well. I think there's a big lack of awareness that this is an issue. So raising awareness. I know in the UK, they have specially trained nurses who work with people with intellectual disabilities, and there's starting to be some research coming out that looks at how effective that is. And I think we should be following that closely in Canada and perhaps adopting some of what they're doing.
I'll quickly add two things. I know we're running out of time. Just want to reinforce what Sandra said about specialist nurses. In the UK, that's actually a recognized specialty of working with people with intellectual disabilities. In the UK, they call it learning disabilities. We do not have anything of that sort here in Canada. I think thinking about what our core curriculum should have as standards for practice in this area is something that we don't currently have. The other thing, and I want to acknowledge not everybody has family, but a lot of people have also community living organizations working with them. So family presence in adult healthcare, I think, is a huge issue. A lot of families are terrified, including myself, to go to the hospital and be told visiting hours are over. Some of the things they use in pediatric care, getting to follow the person into the OR until they're asleep. I think all of these things that provide comfort and help decrease trauma, because this is a very traumatic situation, that are working in pediatric care should be adopted in the adult health system. And so it's been interesting for me recently in interactions to sort of have people say, and who are you? And I'm like, oh, this is new. And so having to say who I am, making sure people are clear that I'm allowed to be present. We've had really good experiences so far, but I think that also has to do with the fact that Eleanor is visually clearly disabled. She uses a wheelchair, she has physical signals to people, but I think it's really hard for people with invisible disabilities to be able to say, I need my mom with me, right? So we need to shift that thinking in adult care to make sure that people have that family and friend presence if they need to have it. So yeah.
Thank you so much. Unfortunately, everybody, we have come to our time, and just a huge thanks to Sandra and Jennifer, and Jennifer has popped the email, I think, in the chat, the corrected email. So I really just want to say thank you for taking time to be part of Rounds today. Thank you, everybody who came, and for the excellent questions. And I seems like we could be here for hours, and it would be a great conversation. So we'll be sure to have you come back.